Digital radiography has some tremendous advantages compared to traditional film. First of all, no more chemicals, no more real estate devoted to storing chemicals, no more lead waste. We get instant feedback, amazing images, and, well, see, that's just the thing. The technology is amazing. The images could be amazing, but for some reason, we're having a difficult time getting diagnostic quality radiographs with the wired sensor. We're seeing a lot of foreshortening and cone cuts, and all too often missing apices. And we have to ask ourselves, why? It's a wonderful feeling to take a great set of x-rays. And it's a crummy feeling when you keep making the same mistakes over and over again. As an instructor at the community college level, I saw my students struggling, and I did everything I could do to help them overcome these problems. Before I get started, I do want to review with you what I mean by diagnostic quality radiographs. What I mean by that is we want to present to the dentist images of the teeth that are as close to the natural shape and size of the tooth as possible. The images need to be complete. So we want to see the crown of the tooth on a periapical. We want to see all the way down past the apices, even 2 millimeters. Human beings, right? So I love taking x-rays on a big mouth, don't we all? I love those wide arches on a relaxed patient who's cooperative. But we all know that's only a small percentage of our patient population. Very often we find people coming in who have a shallow palate, who have crowded arches with malposed and rotated teeth. They've got pushy tongues and chubby cheeks and a touchy gag reflex. and it's just not easy to take x-rays. To top it off, what color is this? Exactly. What color are most wired sensors? Black or dark blue? So, hello manufacturers, we work in a black hole, okay? It is dark in there and it's crowded. And when I'm trying to place a sensor, a black sensor in a black hole and get it distal to the second premolar, it's challenging. And then when my patient closes down and the cheeks cover it, it's really challenging to see as compared to a nice white, crisp, clear film. So I can't condense not 2 semesters of information into 10 minutes of time. But what I can give you is a few tips to go along with you. When it comes to being able to visualize your where to aim your PID, we need to be really familiar with our external landmarks, our anatomical landmarks. So if everyone would please put their fingers on the outer canthus of your eye and then lightly trace down until just about the middle of your cheek with your chin, with the Frankfurt plane parallel to the floor. So place your right to the middle of the cheek and press in. What tooth do you feel? It's your second molar. So when you're lining up the PID, or when you're placing your x-rays and you're lining up the PID, that central ray should be aligned with the outer canthus of your eye. So if you're taking your bite wings or especially your maxillary molar images, that's a great landmark and that will help you. Another difference between the wired sensor and film is the slick, slippery barriers. These don't have that. And then when you place them into ineffective and unreliable sensor holding devices and submerge it into slippery saliva, it's really challenging. So I don't know if you've ever had this experience, but if you've ever placed the sensor, you get it past the lips, you get it past the teeth, You slip it down into the sulcus, the patient bites down and, right, it slips out of the sensor holder. And that is not a confidence booster. So here's tip number 2. I would highly suggest that you throw away your obsolete and ineffective sensor holding devices and invest in equipment that really works for you, that holds the sensor securely right where you placed it. So another difference between the sensor and film is that the film is pliable. It's softer. And we used to be able to massage the edges when we placed it in the patient's mouth. Not with this, baby. It's smaller, but it's harder, and it's bulkier and a lot more uncomfortable for our patients. So what can we do about that? Well, for that, it's important to understand the principles of shadow casting. It's probably been a long time since you played with a flashlight to make shadows, but I have a great reason to do it. You see, X radiation and visible light are part of the electromagnetic spectrum. They both travel in straight but divergent lines, and they both cast shadows. At its essence, taking an X-ray is creating a shadow with X radiation onto your image receptor. And when I say image receptor, what I mean is film, phosphor plate, or the wired sensor. So I'd like you to watch the role that distance plays in creating an excellent X-ray. Watch as I move the light source closer to the teeth. And as I pull it away again, do you see that the images become more crisp and clear? It's hard to tell with these lights. Put it forward again, and you see the magnification. And now you see again, it's gone crisp and clear as we pull the light source back from the teeth. Now watch as I move the sensor farther into the mouth. Again, we have the magnification. Again, we pull it closer, and it's crisp and clear. So what does that mean? What does that tell us? When you place your sensor as close to the patient's teeth as possible, you're going to get a crisper, cleaner image. And those XEP ring holders, those aiming devices, those aiming rings, you don't want to shove that up to the patient's face, actually. If you've placed it correctly in the mouth and you back it up down the stem a little ways, it'll create some distance, it will guide you as you aim, and you'll get a crisper, cleaner X-ray. Another thing, I would just like you to watch the interplay between the light and the teeth and the image receptor. So I can get 4 different images as I adjust my light source. Now we're not going to make radical swings like that, but it can be practical for you in these ways. Do you ever have a difficult time taking the first premolar? It's very challenging because the sensor bonks into the mandible. And so what we can do, and what I would recommend, my 4th tip, is that you rotate your sensor slightly, the anterior edge toward the midline as you place it in there. Bring your PID forward and angle back, and you'll be able to capture the mesial aspect of your first premolar. And another way that this is practical is, have you ever taken a 3rd molar and you prefer not to see the patient's breakfast? Well, place the sensor back as far as you can, tilt the distal edge of that sensor into the patient's mouth slightly, bring your PID back, drop it, and cast your shadow up, and you'll get the distal aspect of those molars. Taking X-rays with the wire digital sensor is challenging. I've been in offices before where I've seen dental assistants wince when they make the same mistakes over and over again, and it subjects them to this awful feeling of everyone wants to do their job well, We get a sense of significance when we do our job well. So I would encourage you to get a flashlight, get a few objects, maybe some salt shakers, maybe some water bottles, and a notebook or something that you can project onto, and play with the principles of shadow casting. I hope this helps.